What I was tasked to do, first off, it's a real privilege for me to join you all today. Thank you for the invitation. And this is obviously something that's near and dear to my heart and my colleagues at the Pacific Neuroscience Institute. When our group started, we aimed to cover all of neuroscience, but the foundation hovered around the treatment and management of neuro-oncologic diseases. And that's where I was brought in. I actually did my fellowship here at the Pacific Neuroscience Institute, as RJ mentioned, with the focus on brain and spine tumors. And that's my passion and my focus. We have a very large group that we work with who are all fully committed to the cause. And I'm going to allude to that here as we move forward. No relevant disclosures here for this talk. So when we're talking about updates in brain tumor neurosurgeries, this is the beginning of the brain tumor month. I think it's important to go a little bit over the different types of brain tumors, the common ones, relative management strategies, and an introduction to what we focus on at the Pacific Neuroscience Institute, the concept of keyhole brain surgery, and my major research interest currently, which is enhanced recovery after surgery. So what do I mean by primary versus secondary tumors? So primary tumors are those that start in the central nervous system, originating from the nerve itself or the support system. While, as RJ mentioned, it's a very rare group of diseases, there's, in terms of total number, they're very, very variable. Currently, there's 126 different types as classified by the WHO, and that number is sure to grow as we learn more. Secondary are those ones that typically arise from elsewhere in the brain and extend into the central nervous system. Now, when we're talking about primary versus secondary, the majority of these tumors are actually metastatic tumors. About 3.5 to 1, all tumors end up being metastatic versus primary. Of the ones that start in the brain, meningiomas are the primary, most common primary brain tumor, followed by gliomas, and pituitary tumors, which is my specific passion. Largely, we don't know why they're caused. There are a small percentage of these tumors that are associated with known radiation, and this is historically high doses of radiation early on in one's life. And some many years later, we've seen this link and correlation. There's been a lot of work and a lot of discussion on head trauma, petroleum, aspartame, and probably most controversial, cell phones, but largely the data is unclear to date. And when we're talking about generalities, symptoms are typically more dependent on the location versus the size. The brain obviously is not a homogeneous structure, so you can see sub-centimeter lesions causing tremendous issues versus 5 or 6 centimeter tumors that the patients hardly feel, as one of the patients I saw this morning. When it comes to treating this, I think this is the most important concept. It takes a village. The symptom presentation varies, and the brain tumor care is heavily reliant on multidisciplinary input. The diagnosis currently, at this point, is only made by pathological evaluation. And interestingly, when two pathologists see the same piece of tissue when they're diagnosing a tumor, occasionally you can get different answers. So there's still a lot of variability in the interpretation that we're seeking to currently improve. It's a large team, and really it doesn't do it justice. There's so many different providers who have dedicated their life when it comes to brain tumor management across the spectrum of the specialties, both inside and outside of neuroscience. And I'm going to come back to this, but it always centers around the patient and their support system, their family and friends. Now, the role of surgery, there's a couple of different ways that people look at it. Some tumors, the main point is just to acquire a piece of tissue to get the histopathological diagnosis. But more frequently, there's an element of resection because to date, the majority of the tumors primarily benefit from a significant debulking or complete removal of the tumor, both to improve the symptoms and to alleviate the mass effect or the pressure on the brain. Now, when we get to that, that's actually a very complicated topic. This is obviously a busy slide. I don't want you to focus on too much of this, but the general consensus is when we're talking about surgery, we're constantly striving for this balance between maximal safe resection, because we've seen in multiple studies, the more tumor you take out, the better patients do. The problem is the second you cause further neurologic deficit to the patient or a symptom that they didn't have, it's like they did not have that major resection at all. So if you induce a deficit, you negate all of the benefits from removing the tumor. That's the general way to think of it. So we're always trying to ride this line as best we can to achieve the best outcomes. Technical adjuncts have helped us remove more tumors. And while the extent of resection impacts survival, so do neurologic deficits. This is how it used to be. Historically, when patients developed a metastatic tumor to the brain, really all the thought process was hope and prayer. But I'm going to hopefully prove to you here in this talk that there have been so many different adjuncts, and while we still have a long way to go, an incredible amount of progress has been made in the last 30 to 40 years. Surgery, followed by whole brain radiation, was introduced in 1990, which shows significant improvements in disease control. And the new treatments, the things that we focus on, minimally invasive surgery, radiation therapy for patients with multiple lesions previously thought untreatable. And now, probably the most exciting of all of these adjuncts with our neuro-oncology colleagues, targeted therapies and immunotherapies, where we're seeing patients with metastatic disease that historically, were felt to have a survival of 6 months or less, living 5, 10, even more years out following the diagnosis of brain metastases. So there has been tremendous work done. So when we're talking about this, how do we make these treatments safer and more effective to try to remove as much tumor as possible without causing more problems? At the Pacific Neuroscience Institute, we consider brain surgery really only the beginning of treatment. We aim to achieve a maximal safe resection and avoid new neurologic deficits, get enough tissue to obtain sufficient tissue for biomarkers and targeted therapies. And a use of the surgical approach, this is my focus, that promotes early mobilization and short hospital stays will optimize patient outcomes and bring them into those adjuvant therapies stronger. So this concept of keyhole brain surgery means accessing the brain via smaller, more precise openings to minimize brain scalp and muscle manipulation. Often we use the aid of endoscopy. By creating less collateral damage to the brain, patients make a more rapid recovery and a shorter hospital stay. We do this through a variety of ways that you may have already seen on the earlier webinars. There's the endonasal procedure coming in through the nose, the supraorbital eyebrow craniotomies, where we can hide incisions into the eyebrow to reach deep portions of the brain, and gravity-assisted approaches using the endoscope, which is a high-definition camera, to really minimize the footprint that you leave on the brain. To do this, it requires a lot of technology, which is one of the big things that drove me into this field. I consider myself a junior techie, and this field really allows me to sort of spread my wings in that realm. This is a quick case that I wanted to show that one of my patients from a couple of years ago with a deep tumor in the brain. And these are some of these adjuncts. This is the normal brain, and I'm going to speed up here for the purposes of time. You don't really see a clear difference of tumor versus normal tissue. Once we highlight this fluorescence or tumor painting dyes that we give to the patients at the time of surgery, we can see a clear delineation of tumor versus the normal brain, which helps guide my resection to minimize that collateral damage. I love these videos because, we're using it now on a daily basis, but this really only came out less than 10 years ago. And the benefits are provided to patients has been very exciting to me. So we can see exactly where we are, work in a safe corridor, remove only what we want to, and patients end up doing better with lower rates of complications. That was a small tumor. This was a glioblastoma in a 57-year-old who was presenting with weakness, gait imbalance, and personality changes, and a whole lot of symptoms. You can see a very large tumor in this right frontal lobe, causing a significant amount of pressure and mass effect on the brain. We use those tumor painting dyes, as I talked about, to help localize and protect the normal brain tissue. Now, even for these large tumors, we can get clear planes and visualization. This is a Sonipet, which is an ultrasonic aspirator that finally cuts up this tumor and allows it to be safe for specimen. Here you go with the tumor painting dyes again. And we're able to dissect, this is sped up for the purposes of time, and really see that border between normal brain tissue, normal brain, and this tumor cell. Even though this tumor was very large and a very invasive tumor, using these different technological adjuncts and keyhole approaches, we were able to achieve a gross total resection of the tumor, and the patient actually did quite well. This is at the end of the procedure, and this is the hole where the tumor used to be, and the patient went home shortly thereafter, neurologically intact. So that's the point that I'm trying to get at here. I'm going to skip this for the purposes of time. We can do these procedures with minimal visual footprint. And when you do that, not only do patients feel better, they get better faster, they also look like they haven't had surgery. And when you're talking about the psychological aspect of cancer, anything that helps the psyche of the patient is going to make a difference in their overall care. These are supraorbital eyebrow craniotomies in a paper that was published by our group, where in the majority of patients, you wouldn't be able to tell which side surgery was done. Now, I wanted to talk about this a little bit here, enhanced recovery after surgery. This was initially developed in Western Europe for abdominal surgery over 20 years ago, and it's using multimodal approaches to improve clinical outcomes in surgical patients. And it involves healthcare providers engaged in a longitudinal fashion to reduce the stress response related to hospitalization. A lot of these protocols and other specialties have shown 30 to 50% reductions in length of stay, complication rates, readmission, and reduced costs. And they've seen this in multiple different specialties. The adoption of minimally invasive surgery is a key component to the success of this ERAS success. I think this represents a paradigm shift in the surgical care of patients, and our focus has been bringing this into the enhanced recovery after cranial surgery. And this is our Pacific Neuroscience Institute specific protocol for all patients undergoing brain surgery with specific adjuncts for brain tumor surgery. And what we've noticed is a big part of this is this discussion with the patient, the family, and the support team, and try to get them as much information and allow them to be as ready as possible to be for surgery, because that makes a major difference in terms of how patients do. This was a great quote that I saw that I've been showing in a lot of my talks and lectures. Operations require a great deal of forethought and planning on the part of the patient. Occupational and logistical arrangements must be made in advance by patients and their families to assist with postoperative recovery. And there's nowhere else where that's more important, in my opinion, than brain tumor surgery, because it's something that completely changes your life. It is a substantially formative experience. And you need to have all the tools, and it's our responsibility to give you all the tools to maximize your chance of success. So in conclusion, brain tumors represent complex pathology. We all know that. Surgery, now we previously thought to be the end-all be-all, represents only a part of the management of brain tumors. Keyhole brain surgery is a safe and effective alternative to traditional cranial approaches, and these technological advancements have helped improve outcomes in this cranial surgery. I think enhanced recovery after surgery represents a paradigm shift in the optimization of care of surgical patients. And brain tumor care requires a truly comprehensive team effort, where neurosurgeons are one of a small group of a very large family of individuals who are wholly committed to making the lives of patients with brain tumors better. So with that, thank you all for your attention. Here is my contact information. Feel free to reach me anytime in the social media that we put out a lot of educational content. So RJ and team, thank you all very much.
We do have a few questions. I know we're running a bit short of time, but we have a couple of questions here. First, this is for Dr. Sivakumar. One patient is asking, what is the best way for a brain tumor patient to sort of prepare themselves prior to brain tumor surgery?
Yeah, that's a great question. And, I had a hard time keeping my talk within the designated realm because I think that's a huge topic. There are a lot of different things. And from the slide, basically the big things is to get educated with with what's going to happen, what is known about your condition, and then the discussion with your providing surgeon. That part of it is huge. And what I would truly recommend is when you go in to plan for your surgery for that preoperative evaluation, bring in one or two of your primary support team members, because it's equally important that they hear everything that you're hearing. Because as you're recovering from surgery, you're not going to be in in the clearest frame of mind, going into it with the distraction of knowing you have a brain tumor and then recovering after surgery. Which you're going to have a recovery process. And then the specific things that we focus on, the surgical details, the surgical site education, nutrition optimization. I have a lot of discussions with my family, with my patients and families beforehand, talking about all of the different ways to optimize their nutrition coming into surgery. Then the medical controlling their diabetes, stopping the smoking, minimizing the narcotics. Currently, right now, my patients require no narcotic medications after brain surgery. And that's actually a frame shift from what's historically been done. So that is also part of the discussion that's had before surgery. And then prepping your activity plans and expectations after surgery, knowing that if you walked into surgery, you should be walking, getting up out of bed multiple times a day, walking around your house, and all of those different things. It's a huge topic.